So thanks, everyone, for being with us. It's a pleasure to be here. My name is Mark Smith. I'm president of the California Healthcare Foundation, and we're here discussing bringing greater transparency to cancer care in California. You have the biographies of our distinguished panel with you, so I'm not going to go through them all, but I will at least point out to you who they are and say a little bit about why they're here. After my very brief introduction, we'll hear from Patty Gans, who's professor at UCLA. Patty is here because, among other things, she's been a leader in the work to develop patient-centered measures of care in cancer, and was the chair of a recent Institute of Medicine committee on the subject, so we thought her presence would be important. Thank you. After Patty, Bob Hyatt, who's professor and chair of the UCSF Department of Epidemiology and Biostatistics. And Bob is here, among other things, because he's been working with the foundation to help us figure out how we can use this underappreciated resource of the Cancer Registry in California to contribute to the greater movement in healthcare to understand better how we're doing and to use the data about our performance to improve our performance. After Bob, Roni Zeiger, who is CEO of Smart Patients, whom I met when he was the chief health strategist at Google, is here because he's going to tell us about his efforts and through the words of his patients, the efforts of his patients to get better information about cancer treatments and cancer treaters. And lastly, Susan Foley, who's a cancer survivor and patient advocate. That's not her whole description. She has her own distinguished career in other domains, but we thought it was important to have the perspective of someone who's been struggling with this issue of where do I go, what treatment do I need, to hear this question from this issue from her own words. So that's our panel, and I'll be brief in trying to set the stage a little bit for not only how important an issue cancer is in California, but why the issue of transparency in treatment comes up. Cancer, it is no surprise to you, is a large and growing cause of death in this state. The next several slides I'm going to show you are from a report that the foundation recently published. It's in your packet. In addition to it being the cause of many people's deaths, it is also an increasingly expensive disease to treat, and you see here the growth in the 12 years between 1997 and 2009. In addition, as with many diseases, cancer incidence rates vary dramatically from one county to another, which is to say your chance of getting cancer seems highly dependent on where in California you live, as is your chance of dying of that cancer. So incidence rates vary dramatically, as do mortality rates. So let me talk for a minute about the Cancer Registry. This is what at the foundation we call the barbell chart. As we'll hear, and as many of you know because you work in this field, the Cancer Registry has a wealth of information at the time of diagnosis. In fact, it has much more information than most electronic health records have. In addition to lots of basic information about the patient, it has information about staging and about cell type, often about receptor status and genetic status, and increasingly there will actually be tissue samples or biobank samples as part of the initial registry information. So there's a lot of information at the time of diagnosis of cancer. At the other end of the barbell, there's a lot of information about the presence or absence of death at specified times, because the Cancer Registry taps into other ways of finding out that information. It may surprise some of you, it surprised me as I began to learn about this, that the National Cancer Database is maintained by the American College of Surgeons, because when this work started, cancer was mainly a surgical disease. You diagnose it, you cut it out. But these days, much of cancer care, after often initial surgery, has to do with other modalities of treatment. So there's medical oncology, there's radiation oncology, there's adjuvant therapy and hormonal therapy, and in fact, the Cancer Registry is less good at folding in all the information between diagnosis and death or survival, about all these other therapies that have grown up in recent years, which is now actually the majority of the way we treat cancer. And a lot of what varies in cancer treatment, and therefore would be important for payers and patients and researchers and drug companies and others to know. Not just surgery and survival or death, but radiation therapy, what modality of radiation therapy, what dose, what side effects, what consequences, medical oncology, hormonal and adjuvant therapy, et cetera. So that's where we are with the Cancer Registry. In many ways, we're starting on third base with cancer compared to, say, joint replacements and lots of other diseases. And yet the registry is not, for the most part, used for quality improvement purposes or performance reporting. Just wanted to point out that in 1997, if you look at this pie chart about where the money was spent on cancer therapy, the vast majority was on hospital inpatient stays, 64%. That's now down to 29%, and kind of as I was saying previously, a lot of the work, the variation, and the expense in cancer therapy is now in such things as drugs, home health care, and hospital outpatient or office-based provider visits, as opposed to cancer's legacy, its origins as a surgical disease. And again, if you look at the use of inpatient and outpatient care for cancer treatment, you see this same trend. So that's kind of setting the stage for why it is we're talking about monitoring performance or trying to understand quality in cancer when we already have vastly more information about cancer than we have in most other diseases. But over the last 30 years, as cancer care has migrated to the outpatient setting and has migrated from primarily surgical to other forms of therapy, there is an opportunity, especially now that those other forms of therapy are often available digitally, to vastly augment our capacity to understand how people are being treated and the variations in their treatment. I will point out, again, there is variation in performance in cancer therapy as there is variation in performance throughout healthcare. For those of you who are my age, you need to get your glasses on, but you will see that there are dramatic differences between one group and another in this state on their performance of both screening, as you see here, and survival rate. And so our capacity to distinguish between high performers and low performers is limited by our ability to retrieve this information, to integrate information that we have now increasingly available with information that's available through the Cancer Registry. And that is what we're trying to figure out, frankly, how to do. There's, as an example of the Foundation's ongoing publication of variations in treatment, this is one with which I'm particularly familiar because of my family. You will note that the treatments for breast cancer, that is to say lumpectomy, varies dramatically from one part of this state to another. And we might expect, as with every other aspect of medicine, that there's dramatic local variation in care without respect to patient differences, but with respect to preferences of physician, local habit and custom, and all the other things that make medical care vary from one community to another. So if you look at the care measures that have been done in California and the United States, and this is with breast and colorectal patients in 2008, you'll see that California does not so well compared to the United States in post-breast conserving surgery, radiation therapy, adjuvant chemotherapy, adjuvant hormonal therapy. In some other areas, it's indistinguishable from the United States, but we know, of course, that averages can obscure dramatic differences between one community and another, between one practice setting and another, between one provider and another. And trying to drill down to that level is what it is that will allow us to all both understand care that's being given and the people who are providing care to improve the care that they're given. So another measure that I'll show you that's particularly relevant to the Foundation's work in end-of-life care is to look at the number of people who are enrolled in the last month of life and the number of days in hospice for patients with cancer. These are Medicare patients. And again, not surprisingly to some of you who are familiar with this field, 56% in the United States, 47% of patients in California are enrolled in hospice, but perhaps disappointingly to many, their period of time enrolled in hospice is not much more than a week. So these are the kind of data that, from our standpoint, might be collected, should be collected, might be better integrated with all the various sources of data that are now available in treating people with cancer to give us a more robust dashboard, to give us a picture of how care is organized and delivered. As we'll hear from our panelists, when you're going to choose a provider, you've got a bunch of places to go to, and you've got a bunch of places to go to get that information. We'd all like to have better, more robust, more standardized, more reliable information in this field as in others. And that's the objective of the Foundation's work here, and that's why we're grateful for those members of the panel who've agreed to come participate with us. So I'll now ask them all to come up, starting with Patty.
Thanks very much, Mark. I think you've really set the stage for what I'm going to be presenting to this audience today. Let me just say I am a medical oncologist. I am one of those people who contributes to the extra costs of care in the outpatient area, and I am a native Californian, so I have a vested interest in all of what's going to go on here today. So about 14 years ago, the Institute of Medicine, which is a portion of the National Academy of Sciences that advises the nation on health, and that's our role, developed a report on how we should ensure quality cancer care. And the conclusion, the main conclusion of this report was for many Americans with cancer, there is a wide gulf between what could be construed as the ideal and the reality of their experience with cancer. And at that time, this was a landmark, pioneering study that really grabbed everyone's attention about what was going on, and there were many, many issues that they were grappling with. Among the 10 diverse recommendations that they presented was the need for evidence-based guidelines in cancer care, the need for quality measures and electronic data collection systems, the need for coordinated, high-quality care, including at the end of life, clinical trials and comparative effectiveness research, and a big emphasis on access for the uninsured. And there was a lot of work on screening in that report, which to some extent those gaps have been improved by some of the federal legislation that's helped with that. But in spite of this landmark report and a lot of attention that was paid to it, there are still many gaps today. And that led to this new report, the committee study of which I chaired, which is called Delivering High-Quality Cancer Care, Charting a New Course for a System in Crisis. And our conclusion was that cancer care in the United States is often not as patient-centered, accessible, coordinated, or evidence-based as it could be. And you can hear some of the same words that were written about in 1999. And this report concluded that the cancer care system is in crisis, and in the next few minutes I hope to tell you about that crisis. And we made very specific recommendations for how we could chart a course to deliver high-quality cancer care. So these are some of the trends amplifying the crisis that our committee was very concerned about. Cancer is really a disease of the elderly, and I'll show you an incidence curve in a minute. 30%, there will be a 30% increase in cancer cases in terms of new cases by 2022, and 45% by 2030. And again, that's just by virtue of the aging of the population, 10,000 new individuals turning 65 every day. We have workforce shortages. We've heard a lot about primary care workforce shortages, but we have huge workforce shortages in oncology. So who's going to take care of those patients? There's tremendous reliance on family caregivers and direct care workers. A lot of that's things that are not being done in the hospital are in fact being done in the home. And we're impressed with very serious increases in the cost of cancer care, and you can see the numbers here. Cancer care, while we are curing more individuals, have more survivors, is far more complex than when I started my training in the late 1970s. And we really haven't gotten very far since that 1999 report in terms of tools for improving the quality of care. And this is the incidence curve that you can see here, again, with a peak in incidence around 65, 74, and mortality subsequent after that. So if you think about who is getting cancer, it's your parents, your grandparents, and your neighbors. To inform our report, we had actually a workshop on delivering affordable cancer care in the 21st century, and the website is there that you can download the report and look at it. This is where we got some of the shock regarding the costs of care. And on the right and on the title of this slide is an article that was recently published in our premier oncology journal, written by medical oncologists, asking about the just price of cancer care drugs. Of course, we know it takes a lot of money and time to develop these drugs, but the monthly cost for many of these drugs are $36,000 a month for a new melanoma drug, and as low as maybe $5,000 or $6,000. So how does it get priced this way, and how can we afford it? We also wrote another paper reflecting the workshop, and again, this just shows you on the left a table showing the inappropriate number of colonoscopies being done in people over the age of 75, where it shouldn't be done. And then on the right, some of the off-label use of some of the very expensive drugs. So a lot of things are kind of out of control in our current healthcare system. This is, again, something that we're very proud of. There are over 14 million cancer survivors today, but this is expected to go to 18 million in the United States. And as we look at these numbers, in California there are 1 million cancer survivors, about 3% of our population. The cancer care continuum here is presented as we looked at it, and again, as Mark has already told us, it involves a lot of complicated therapy. Again, bringing to your attention the data he presented about end-of-life care. Cancer at the end of life in California is more expensive than anywhere else in the country, more intensive use of resources at the end of life, and less use of hospice. So to make our recommendations, we developed a conceptual framework for how healthcare quality should be delivered for cancer. And at the center of this framework is the patient, who needs to be informed and engaged, needs the support of their family. They need to have effective patient-clinician interactions. The workforce has to be prepared. We need team-based care where nurses and physician's assistants can work to the level of their training and credentialing, change the laws to address that, and we need to have evidence-based care and a quality reporting and monitoring system. So these are the recommendations. I'm not going to go through all of them. Again, you can look at the report, but I'm just going to concentrate on the ones that are highlighted in red because I think they're particularly relevant to our conversation today. Recommendation 6 called for better data, and it again asked the actor in this case to be the National Cancer Institute to lead federal agencies, the Patient-Centered Outcomes Research Institute, clinical and health services researchers, and others to develop a common set of data elements that captures the patient experience and relevant patient characteristics and health behaviors that might be influencing their outcomes. And not just in clinical trials, but in observational studies. I want to say that our California Cancer Registry is funded by the National Cancer Institute. It's part of the SEER program, so it's highly relevant that we're talking about this here today. The recommendation 7 was for a learning healthcare system, and many of you may not know what this is, but people at the IOM and others have been talking about this for a while. We collect so much information about what goes on in healthcare. Couldn't we learn about the experiences of patients from the data collected in the medical record and merge with other data from claims, from the California Registry as an example, to really look at cohorts of individuals who are not getting on to clinical trials, where we don't know about their experience and we don't know how they're doing, so that we can improve the care. And again, the call here is for CMS and other payers to create incentives for this kind of transformation to occur. Recommendation 8 focuses on quality reporting, and again, the actor in this recommendation was HHS, should work with professional societies. We believe that professionals involved in cancer care should help develop these metrics, but we need a long-term strategy for getting meaningful quality measures in cancer. Right now, they're focused on little process measures that don't necessarily link to outcome in all cases. And this needs to be publicly reported in a way that the consumer and payers and providers can know how they're doing. 9 is to reduce disparities. Again, we have tremendous disparities in how care is delivered. Here we made a recommendation that we should really leverage local efforts because these kinds of transformations occur at the local level. And again, here in California, with the diversity of our communities and the kinds of disparities that you already saw reported here, we need to work on this by innovative programs that address these issues. So in conclusion, again, I encourage you to look at the report and read about it in much more detail, but all participants and stakeholders must reevaluate their current roles and responsibilities in cancer care and really work together to develop a higher quality cancer care delivery system. We cannot wait. The onrush of patients, the costs are really facing us in a crisis. We need a coordinated and transparent reporting system to be able to do this, and we need to work together to improve the quality of life and outcomes for people facing a cancer diagnosis. I'd encourage you to look at the report. You can, again, read it online. And we have a terrific video with patients telling us about their experience. Takes about 20 minutes. There are other clips in there that you can look at, but really tells the story. Thank you so much.
Thank you. Again, my name is Bob Hyatt. I'm an internist and an epidemiologist. An epidemiologist does not study skin. They study epidemics and the distribution of disease in populations. And one of the things I'm interested in is the quality of cancer care, how you measure it, how you use it to make a difference. I'm going to tell you a little bit about a work group that I chair that's really trying to understand this problem in more specificity and trying to do something about it. So basically, I've got 3 points I want to make for you in the next 20 minutes or so. One of them is to describe what cancer registries do, what they do now, what they could do is the second point, and then third, what are some of the issues that we need to address in trying to improve the system for patient, provider, and payer transparency. So the problem, as has been described, the questioning and the lack of transparency and information that people face when they're diagnosed with cancer. Where do I go? Who do I see? You know, what are the costs? What is the quality of the care? So right now, it's very difficult to navigate these waters. And the question is, what can we do now to help lead the way? So, cancer is a unique opportunity because of several things. One is the cancer registries. Now, California, the whole state is covered by a cancer registry. Cancer registries exist by statute. Doctors are required to report cancer cases. This has been true for at least 50 years. It's like measles, mumps, or tuberculosis. You have to report it. And that responsibility is given to hospitals, and it rolls up until you get data that can be used both at a state level or a county level or at the national level. So this is actually a very good thing for understanding cancer. And many other diseases really can't even count the number of cases that they have. It's being made better, easier by new informatics and technology. We're in a time, especially in California, where we've got tools that can improve the whole process. And we have, as Patty has suggested, as well as Mark, a multidisciplinary approach to this, where you've got many different types of cancer doctors, you've got people like me in epidemiology, you've got nurses, you've got psychologists, sociologists, lots of folks trying to understand the overall problem. That makes it richer, makes it better understood. This is the work group members. I'm not going to read them, but I want you to maybe go down the left-hand column and see what kind of people we're bringing to the table in terms of disciplinarity. So oncologists, people who worked in registries for a long period of time, health quality experts, economists, outcomes researchers, legal counsel, advocates, and medical oncologists. And all these people who you see listed here are really experts in their field. So it's a fabulous group that the Foundation's put together, and it's an honor for me to be chair of this group. So we're meeting on a regular basis to try to tackle the charge that's been given to us. And that's really to, what are the barriers and opportunities for leveraging what we have already, which is the California Cancer Registry and other systems, for improving the quality of cancer care. And specifically, we're looking at a vision of the future, which we think California can lead, of developing quality metrics by provider to allow for improved decision-making by, as I've said, patients, plans, providers, and others. So what do cancer registries do? Well, if you go onto your california.gov website, you can actually look it up and see. You can sort of scroll through and see all the things that our government supports us to do in the California Cancer Registry. It's quite remarkable. What we have in California is one of the best, I think, cancer registries in the country. It's due to the good work and the long work of cancer registrars and leaders we've had here. You should all be proud of this. You may not even know about it, but check it out, because it's a jewel in our research and governmental crown. What do they do? Well, they monitor new cancers, and that allows you to look at, and if you count them and add them up, like I've said, you can look at trends over time. Is it going up or down, as you saw in the first presentation? You can make judgments about whether things are getting better or worse, and you can look at it for the whole population, not just the one hospital or one provider group. You can document disparities, because you collecting information by gender, by race and ethnicity, by county, and you can see things like that map where you see higher rates in one county versus another. Here we are in the California State Association of Counties. Those of you that are concerned about counties can see actually performance or statistical differences between the geographic regions. But you can also look between race ethnic groups and try to understand why there are differences there, as well as socioeconomic groups and other subpopulations. Cancer registries help us by providing the ultimate way of judging health impact of anything that's changing over time. So if you're looking at the impact of the Affordable Care Act, we will be able to see whether there's any correlation between cancer incidence and cancer mortality over the next 10 years or so, associated with the major changes in the healthcare system. And it's a good tool for research. So it generates hypotheses, generates ideas that stimulate people like me in universities to try to get deeper into the causes of these differences. Now, what could they do? So what we already do is pretty impressive, but what could they do? Well, it could be used for quality of cancer care assessment. If we were able to merge cancer registry data with existing other data sources, like electronic medical records, like medical care utilization data, we could get information on medication use, imaging, information that would fill in the bar in that barbell. And this would, we believe, provide better and more transparent information for informing decision-making on the quality of cancer care. So just to revisit this barbell, the kinds of things that we don't have in registries are what happens in terms of the depth of the first round of treatment. That's not fully captured. We don't know about recurrence. That is something when a cancer recurs before it has a consequence of death. And we don't know anything about subsequent treatments. So all of that exists already in utilization data and in the electronic medical record, but it's not connected. And we want to connect it. So that's the vision that we have, is that the California Cancer Registry could be connected with existing medical records in different provider groups and utilization databases, such as the Medicare database. So some of these linkages already exist. This isn't just being completely theoretical. There is a linkage between SEER, which is it stands for the Surveillance, Epidemiology, and End Results Registry. It's the national registry that has been mentioned. That has been linked to Medicare. And so for individuals over 65, you can learn things like mammography utilization, procedures performed by surgeons related to complications, estimated costs for different procedures and screening. And this has been great. It's been used for a lot of different insights into quality of care, but it's limited in terms of the kind of information you have on treatment. It's only for persons over 65, and things like radiation and chemotherapy, which are two important treatment types, may be incomplete even in that database. So what about electronic medical records? Well, guess what? While you've been napping, electronic medical records have really become much more common. This graph shows from the Journal of Oncology Practice just this year that about 61% of practices in this country are using electronic medical records. Another 16% have used it as the basis for their work, and another 15% are looking into it over the next 6 months. So it's essentially going to be de rigueur for practices to have electronic medical records. So what are we looking at in the work group? Basically 3 things. There's some technical issues here. There's some stakeholder concerns, and then there's some legal and regulatory issues. The technical issues, just to give you the highlights of them, are in how to make cancer registry data more rapidly available, more timely for use by providers and by payers and by patients. Right now, it takes a while to ensure the quality for this kind of cancer registry reporting. We would like to see that sped up. We want to improve data capture and physician workflow. That's a technical issue that needs to be tackled. And we want to decide what are the relevant domains of cancer quality care measures. In other words, the measures that you're going to use, the metrics that you're going to really tackle, standardize, and use across the system. And of course, there are cost issues. The stakeholder concerns are basically what you might think in a cultural sense. Provider entities may be sensitive about making quality of care performance data available to the public because they're being compared to other providers, and there's costs and competitive issues here. But you've already seen examples of this from the mammography results that were presented in the first presentation, and I think this is becoming more and more common. Yet it's something that the work group wants to consider. And patients are also concerned with their privacy, so individual reports and individual information have to be protected and kept confidential. And finally, legal and regulatory issues. So the current law on the books is that cancer registry data can be used for research, for bona fide research, but public release of providers are prohibited by law. So unless we find some way to change the statute, we can't really talk about the quality measures that we can develop technically by provider type. So what do we think of? What are we looking at? What's the vision of this work group, and what are we thinking about in terms of the charge that we've been given by the foundation? So one is we want to improve the timeliness of data release through automation. We have the technology to do that, and there's some experiments in play now that are showing us the way to that goal. We want to make additional data linkages for the registry to EMRs and utilization databases. We want there to be a bi-directional flow of information between registries and providers. So providers benefit from having more readily available data, higher quality data. Vice versa, registries can improve the work they do if they have better access to provider information. Our registries, by the way, the people that work in the registries, I think in general are eager to explore some of these new methods, because I think California can lead the way in making some progress in this area, and they want to be part of it. And then finally, the metrics to quantify quality of care among providers is work to be done, and something that we believe we can contribute to. So the impact, finally, is going to be, with this vision, improved transparency of the quality of care, better information for patients, opportunities for patients to be actually engaged in their own decision-making. It's not going to all be based on quality. It's going to be based on cost, based on how close the provider is to them and how far they want to travel. Those kinds of complex decision-making issues have to be taken into account as well. And added value for cancer registry programs. So as we're moving into a technology-rich age, how can cancer registries be part of that? And then we can address health disparities more intelligently. So our goal is to have better information for patients, for providers, and for payers, and for other stakeholders to inform decision-making and the quality of cancer care. That is as succinct as I can make it. You can see what the elements are that go into it, and I think it's a great vision and something exciting to work toward. Thank you. Thanks, Carl.
Hello, everyone. I'm Roni Zeiger. I'm a physician. I know almost nothing about oncology, so you'll forgive me about that. I'm an internist, but I've had the privilege for the last couple of years of working with online communities of cancer patients, where I've been learning a tremendous amount, and I think there are huge opportunities for us more broadly to do the same. Just to set the stage, some things that most of you probably know, but people are looking for health information online. They're hungry for information. They're looking to learn from each other's experiences, and they're thirsty for anything they can find about the providers and healthcare systems that they're choosing to get their care. This is at least as true among cancer patients as among all others. Now, the California Healthcare Foundation asked my company, Smart Patients, and our communities of cancer patients to do a survey to contribute to this conversation today. And what we asked, I'm just reading here from the bottom, how did you choose the doctors and hospitals where you have gotten your cancer care? And what more would you have liked to know in order to make those choices about where to get your cancer care? We've had about 50 respondents to those questions, and they ranged across most of the spectrum of oncology. And I want to share with you now some of the key themes that have emerged and very specific examples. So just a reminder, when dealing with these issues ourselves or with our loved ones, we're terrified. The first question actually isn't a question, it's usually an expletive. Since this is on camera, I'll not say it out loud, but I have a guess that you could guess at it. And that quickly evolves into getting down to business. And these are quotes from the responses to the survey across the online cancer communities. My uncle was recently diagnosed, and we've chosen to go with Dr. X in New York City. Does anyone have any experience here to help us assess whether this is a good decision? And these decisions are not just having potential life and death consequences for ourselves or our loved ones. They have dramatic impact on our personal finances. My father's in China now, and I hope to talk to a specialist to help decide whether it's worthwhile to bring him here to this country. And you wouldn't be surprised if ignore the fact that some of you have significant medical or even oncological backgrounds. If these questions were all of a sudden facing you or a loved one, you would do your homework. In a short number of months, you would become surprisingly expert at the narrow aspect of medicine, in this case oncology, the narrow aspect of oncology that you need to make very difficult, subtle decisions about. And the questions that you might ask could include, does anyone have a list of SRS, stereotactic radiosurgery, versus whole brain radiation-friendly radiation oncologists? These are questions that real patients and their families are asking, and the data that we, the Royal We, are providing them to help make those answers are largely lacking. Now, patients are also often talking about clinical trials. Remember, this is oncology. Many patients have already failed the 1 or 2 or 3 approved drugs for their therapies, and their next best options are in trials. So patients are asking each other, they're asking their clinicians, they're asking the internet, which trials make the most sense to me. And many physicians, we hear anecdotally, I don't happen to know whether there's validated data about this, but physicians are often reticent to talk about clinical trials, A, because they often don't know a lot about them, and B, the trials that they do know about or have incentives to refer people to are at their own institution. Again, this is a transparency issue about where to get one's care and in what way. Now, it's not appropriate for everyone to get the most aggressive care. What is undeniable is that everyone should have a clear and transparent choice about what their options are. This 44-year-old woman with esophageal cancer and young kids sought out more information than her initial doctor offered her, and she's, of course, delighted that she can tell us that story 11 years later. I would have liked to know more about the treatment options not available at my cancer center, to discuss options offered elsewhere, even if my doctor did not think they would be a good fit for me. What we're talking about here is transparency and choice. It's about having conversations that have real data as context and conversations among patients who want to be partners in their care, not just passive recipients about what subsets of the healthcare system tell them they want to do. In the beginning, it did not occur to me to question my doctors. Every patient should get a second opinion. If you're going in for more than the flu, go armed with knowledge. Patients are asking us to arm them with knowledge. There is now a significant amount of data. A quintessential example is that which is in the California Cancer Registry, which we can make available to more of the collaborators, including the patients who are involved in these very difficult decisions. The kinds of questions that we could relatively easily help patients answer without getting into very controversial things about what is quality and who is really better or worse. For my cancer, how many cases has my doctor or hospital seen this year or ever? How many times has he or she done this procedure? What treatments have they offered in the last year, 2 years? What's on the potential menu for this oncologist or this radiation oncologist or this surgeon, based on the things that have been reported and are objective? We started this conversation in the SpartMations community. Even though we told them that the meeting was going to be today, they won't stop talking about it. So I'm going to read you a quote from last night that I didn't have a chance to put in the slides. I wanted to get an expert opinion or perhaps care from a high-volume center. My hospital was unable to tell me how many esophageal cancer patients they treat annually or how many esophagectomies they perform annually. They were unable to tell me how many my surgeons had performed. I made inquiries through various connections and resources. Most returned positive but subjective references. No one was able to provide me with objective data. Our patients are asking us to let them help, and we need to do so.
Thank you all for having me here. With every speaker, something resonated with me. I was writing things down because 14 years ago, I was diagnosed with stage 2B breast cancer. I was 38 years old. My name is Susan Foley. This is a picture at a celebration party of my mother and I. I had gone through 7 months of chemo, radiation, surgery, and then years afterwards of hormonal, all of these different treatments that you have been discussing here. I'm here to give you the patient perspective and remind you of the end consumer. So my speech isn't so much about the slides, but from my heart here. The picture I decided not to bring was my 3 young children. I had, at that time, a freshman in high school, a 5th grade daughter, and my youngest was starting 1st grade. Ironically, the year before, I had just run a marathon. It was very impactful to our community because I was involved. I was a full-time working woman in San Francisco with a big job, which I'll go into in a little bit. And with these 3 children in elementary school and high school, and if you lined 10 women up, they would say she would be the least likely to have cancer. So that feeling of devastation, that first question, the bad word that you say, that was all there when I got my diagnosis, because I had my children early, I had breastfed them, I had no history, and I found a lump, and I was told actually by the general surgeon, I'm sure it's nothing. You're in perfect health, you don't even need to have it removed. So I thank God every day that I did in fact have it removed, because it was stage 2B. My career at that time, I was in the investment business. I'm a chartered financial analyst. I was a partner at a large investment firm. And what was amazing to me, on any given day, I could sit in front of a computer and find out information about any company, any industry worldwide. I could find out what their products were, what their sales were, what their return on equity, their margins were. But I couldn't find the information that I needed to on cancer. So I am one of your most sophisticated users. I am tremendously lucky that I was so well connected that people could get me into the great places that I was able to shop for my health care. What I've come to find out was, for most people, first of all, the diagnosis is so overwhelming. But secondly, they don't even know what the next steps are. And at the time when I was going through this process, there was a procedure called sentinel node biopsy. And for those of you that don't know that, in the old days, they would take out 30 lymph nodes out of your arm, and to see if cancer had moved on, had metastasized there, or had, and that would mean that maybe it had gone through the rest of your body. But this procedure was being done whereby they could look at, if you say Highway 5, and see that the cancer hadn't gone there. There was no reason to take the lymph nodes of all the streets in Sacramento, because you had to get off on Highway 5 to get to Sacramento. So this was really revolutionary, and it was great. But it's important. The more you do things, the better you do them. So you don't want a surgeon that is trying their first sentinel node biopsy on you as a patient. We want everybody to get better. But you want to know that your surgeon is teaching the other surgeons, if you can. I mean, that's what I wanted to know. So there's just no information on that. There was no availability. To one of the panelists' comments on lumpectomy versus mastectomy, I wanted to know my patient population pool. Who's doing them, what their outcomes are, and how does it work for 38-year-old women who are already in a bad patient population. So that is the kind of data that was really not available, and is still not available. And so I get a call, once a month, once every 2 months from people, and they're trying to navigate these decisions. They're trying to find out where there's some transparency. What's the difference? It's not that one's better or worse from being at a big research hospital versus being at a private practice. We're not trying to say, in my opinion, that we need to say, always go to the research hospital because you're going to get the latest and greatest. But the patient should know, if this is important to you, or for your type of cancer, or for your type of case, and here's the trade-offs that you're giving, or here's the important things about private practice. And once again, when I think about this, my little 5th grader has grown up and is starting her first year at Kellogg. And she called last week and she said, Mom, Chicago's really cold as compared to Palo Alto. And I said, yes, I know. And she said, I need a good coat. And I said, well, I heard there's these special coats you get in Chicago. Within 20 minutes, we had the warmth factor on all the different coats, brands I had never heard of. She ended up getting one from Canada, of all places. But you can't find that out about our health care, about cancer there. So I encourage people to understand that I was the best case scenario. The barbell, that data is what I'm most interested in now. I did the 5 years, and now I've come to find out I want to know what actually happens next, and what I can be doing. So I thank the group for my time here, and give it back to you, Mark.
Thank you.
So our panelists have been good citizens by sticking to their time, and now it's time for questions and comments and answers. And reflections from you. Questions?
Beautiful job of presenting the issues and challenges, and I particularly appreciated the survey and the cancer survivor perspective on this. I'm excited about your work group putting together, and I'm confident that good work's going to come out of it. My question is translation. In other words, let's anticipate that the work group's going to say this is exactly what needs to happen with the registries, with the electronic medical record, with Medicare databases. What's going to incorporate this into practice? What's going to make this happen? And I'm thinking particularly about are there aspects of high tech, you know, the meaningful use component of the electronic medical record, or will ACOs pick this up, the accountable care organizations or affordable care organizations? What mechanisms will actually make will carry your recommendations into practice?
I didn't have time to go into the great detail that I would have liked to, but our last recommendation really relates to payment reform. And without a quality evaluation system, we have no metrics, if you will, to evaluate how people are, with the care they're getting, the value, if you will, of the care that they're getting. So that's very important. And to the extent that we can eliminate wasteful procedures that are not necessary, that are not evidence-based. Right now, if a physician puts in a claim for something, it's paid for by Medicare, as an example, or many payers, because they do not have the amount of information in the claim. They know it's somebody with breast cancer, but they don't know if it's a patient with advanced breast cancer or early stage breast cancer. They don't know if this is the 5th line of treatment or the 1st line of treatment. They don't have any of that information. And so they're paying it because it's an FDA-approved drug or procedure or whatever else. We need to link the payment with the evidence and the quality metrics, okay? So it's not necessarily, you know, saying individual physicians can't do this, but when things are paid for, they have to have a reason behind them. From the consumer side, having these quality metrics available may strongly influence the choice of health insurance plan you may choose the next year. If you're on a very expensive cancer drug, as an example, and you know that you're going to be taking this the rest of your life and it's costing $10,000 a month, you'd like to know if the pharmaceutical coverage you're going to sign up for starting next year is going to have this on its plan, what your copay is going to be. But right now, you know, you don't have an ability to deal with it, so that's a pricing and cost issue. So there are many, many places in which we need to deal with it. But, you know, again, the translation is going to go on in California, and it's going to go on, we hope, all over the country.
Yeah. So what the work group's going to do is so if you take your, like, if I try to answer your question in a stepwise fashion, I mean, Dr. Gantz is right. I mean, ultimately there needs to be a system that incorporates this. But we're going to issue a report of our findings. We're going to publish it. But we're going to make it available to the actors in society who can do something about it. Now, those actors are going to be cancer registries themselves. They're going to be providers that can make use. I mean, if this data is more useful to providers, they'll start paying more attention to it and, I think, contributing to it. And I think it's also going to have some discussion and impact in the legislative arena, because some of these things are not possible now because of restrictions in the legal statute. So there's different sort of actors out there that we are addressing in this effort. And I think if each one of them has something to benefit from and sees that benefit, I think this will become more incorporated. This idea, this vision, and actually the practice will become incorporated into what we do. And as Dr. Gantz has said, you know, if the systems are there and the value is recognized and there's some incentive to participate, that will also help.
Let me ask Roni and Susan to contribute. You know, the internet didn't exist when cancer registries were invented. And I know that before and during your time at Google, Roni, one of the things you explored was the value of machine learning as opposed to kind of expert opinion. So a lot of what we've been talking about here is in the realm of expert professional control, where one group of professionals sends data to another group of professionals who decide what's important and they issue professional ratings. I guess I'm interested in your and Susan's views about how the more peer-to-peer world that you live in and that Smart Patients lives in and that your experience has helped you gather, how could that contribute to a revised vision of where the data comes from and how we help patients and their loved ones and referring doctors? Let me just say, most of the doctors in the room have had this experience. I've been a doctor for a long time. No one has ever called me and asked me for a recommendation of where to send their kid with mild asthma, right? But when my best friend got prostate cancer, he called me up and said, okay, Mr. Quality, where do I go? And I told him, I can tell you who's famous, but I can't tell you who's good, right? So from patients and from referring doctors, what does the new world of peer-to-peer based information and knowledge have to contribute to a new view of the dashboard for cancer information from both of you?
Well, ironically, when you said I was able to put together, because of my community and access very quickly, but most people couldn't do this in 10 days, to your point about who was famous but maybe not so good. So who was famous could raise money, but maybe you didn't want them to necessarily be your surgeon. And so you have this little underground community to the point that you get plugged into somebody like that. My hope is the data is so important, and we have stakeholders, as you've alluded to, on every side. And I think that we're getting to the tipping point, maybe because of demographics and the number of people that will be getting cancer and because of the baby boom generation, where people will actually, they really do want these answers. I think in the past, people were willing to say, I'm just doing what the doctor told me. And it's a different generation that's grown up wanting answers. And so for me, for instance, I know that HIPAA, we want to protect the right of the patient. I don't need to know the name of the patient, but I sure would love to look at data of every other 38-year-old that was diagnosed with cancer, that didn't have any genetic background to it, that had lived in California and ate vegetarian or something. I'd like to know that. So I think there's a lot more of me coming up and are going to be asking those questions. And I think these new consortiums of workforces, whether it's technology companies that are doing their own self-insuring in a way, and they will have that data on populations, you'll start looking through it and be able to see some things that'll become more exciting to the scientific community, which will further propel it. That's just my humble opinion there.
Roni?
I'll say something perhaps a little bit controversial and then something practical. The potentially controversial part is that I think many of us wildly underestimate how smart so many of our patients are. And I do not think that we will go to patients and find the answers to all of our most important questions. However, extremely low-hanging fruit is that patients are asking the most important questions. And I think that spans all the way from where we should be putting our research dollars. We spend very little time asking patients what our research agenda should be. And they ask very practical questions like, how many esophagectomies has this hospital done? And it's, I think it's foolish and unethical to not provide that information when it can be readily provided. So we will learn a lot as we get better to listening to our patients. Now, the really practical part is that patients are very practical, and we have been dancing around in circles for decades now, arguing about what is quality in medicine. How do you define quality? Measuring outcomes is one of the most complicated fields in the history of the universe because it's never comparing apples to apples. Everyone's got different referral biases and things which I will never have an epidemiology degree because it drives me nuts. But the opportunity here is that patients are asking some very simple questions. How many? How often? Not how good. We don't have to solve how good, but if we follow this very simple demand on the consumer side, we will start a virtuous cycle of here's a little bit of data, and then we'll have this whole population of people saying, thank you, that's interesting, this helps us. And you know what else I wonder? And that will take us towards places where we can't get fast enough if we only do it in an academic context.
It seems to me, or I just recently became aware of the issue, I'm not at all involved in the medical field, of just the difference in costs of care. So for example, if I'm going for a colonoscopy, you know, I go to where my doctor told me to go, but I've since found out that, you know, within my region, there's thousands of dollars of difference. Now, I don't have the ability to determine, you know, somewhere is this one that's this much less money of good, you know, of equal quality and all of that. And it seems to me that I would be very much willing to be a much better health consumer if that information was available to me, which seems to me could have potential to save huge amounts of money in the healthcare system. But we're, as consumers, you know, I have health insurance. My doctor tells me to go somewhere, and I go somewhere, and that's all. You know, I might get a piece of paper that tells me how much that costs, but I don't know. I don't have anything to compare that to, I guess, without doing a lot of research. So I just want to understand, is that kind of part of this work of looking at the costs of care as well as quality kind of indicators?
Yeah, you know, I actually think you've said it perfectly. You know, you as a consumer are used to looking at costs of things, but you don't if you know what the quality is. So if we can provide a way of judging quality, we can leave it up to you to do the shopping on the cost.
I also think some of this is determined by what in the field is called benefits design. If hospital A charges $5,000 for a colonoscopy, and hospital B charges $10,000 for a colonoscopy, and your individual health insurance benefit is designed in such a way that you are indifferent to that. That is to say, if you pay $300 no matter what it costs the insurance company, you're not likely to spend much time on that. If, on the other hand, the insurance benefit is designed in such a way that you're going to pay the benefit is $4,500 for a colonoscopy, which is to say you'd pay $500 one place and $5,500 someplace else, I suspect you would now get involved. And the reality is, for most of us, 10 years from now, we will have insurance policies that look somewhat more like that latter case than what we're used to. Because the reality is, as you say, for many people in the public, they've just recently become aware of this. Insurance companies have known this forever and basically have kind of averaged it all out. But increasingly, both insurers and employers are designing their benefits in such a way that, in essence, we now have to be aware of and in some cases be responsible for these dramatic differences in what providers charge. And I think, as all the members of the panel would probably agree, we don't have very good quality data now, but once you've been asked to pay twice as much for something, you're likely to say, excuse me, Hospital B, could you please tell me why I should pay twice as much for yours as opposed to theirs? So this is, I think, one of the virtuous cycles that Roni talked about.
I think that there's a lot of, I'm hearing, dependency on how good the cancer registries are going to collect data for us. But has anybody addressed the consistency of the data collection itself? Right now, this state is broken up into several regions, and I don't think the data collection is consistent throughout the regions. I've seen many data changes in 1 year over one site. Who's making those decisions? How can your data be consistent if changes in data collection happen for one site 3 times in 1 year? How is a researcher or a clinician going to make decisions based on that kind of decision making of the data collectors? And I'm not sure who's making these decisions. I'm not at that table necessarily, but I've had registrars that come to me from other regions, and that's not how we did it in region X, but this is how we do it in region B. And that's, to me, a serious issue when we're going to be so dependent on the quality of this data collection. So that's one issue right there. Another issue is we have a serious shortage of qualified cancer registrars. That's known throughout the state, probably throughout the nation. The reason why is they're not dealing with reimbursement. So they can't ask for the same amount of money, let's say, as coders do. That coder community is racking up the bucks right now because of I-10. But are these people who are looking into what we can collect from what the coders are going to be doing? Because they are going to be collecting certain things about radiation and I-10 that's going to give you some very specific data that will save some time on the part of the registrars if it could be interfaced electronically into our systems. Right now, that CNEX system is still fairly antiquated. It doesn't play well with other systems, and that's something that I suspect your team is going to be addressing. Those are some of the reasons why we are in the places that we are today, is because we haven't addressed those. And I really hope that this team looks at what OSHPD has been doing for the last 30 years in data collection across California that has been much more consistent. It's timely. Within 6 months of the fact that the data is closed, it's available to people to look at. And cost of care is available through that site. How many laryngectomies is available through that site too. So this information is out there, and sometimes related to cancer, it's available. People just aren't using it.
Your comments are appreciated because some of the technical aspects that I referred to do relate to the nature and the quality of the information that's in the cancer registry. So these are concerns for sure, but on the positive side, I think the questioner would have to agree that there's a lot of very good information in cancer registries that have allowed us to make some smart decisions and smart judgments about the patterns and the behavior of cancer over the last 50 years. So we've got a really excellent tool that we should improve and work on, but there's no question that there are technical issues and personnel issues and challenges for the future, because registrars aren't trained necessarily in capturing quality of care measures, and how that's going to occur is also part of the technical aspect of making this happen. So good points.
So I just also wanted to say, I think we have to envision this new future, the conceptual model that I showed you, and that, yes, registrars may not be as well paid today, and there may be personnel. On all of healthcare, we're going to have shortages. It's not just the physicians. But if this has value to the payers, to the consumers, and others, there are going to be many people who are going to be willing to invest this, because it's already legislated and mandated that we identify the case of cancer. And that's the biggest limitation of electronic records now, is the case identification problem. The registry is already doing that. So with a little bit more investment, and it doesn't have to all come from the state, although the state may facilitate it in terms of legislation and other authorizations, but the private payer community could in fact enhance the resources available, because the value added from what we can gain from this kind of rapid learning health system would be enormous for everyone.
So let me just say, I'm going to get to, I'm not an expert on cancer registries, but in the couple of years that I've been doing this work, I've learned there's lots of history here. You know, there's history to why there are regional systems, there's history to why people do things the way they do, and a lot of people in this room know more than I do. But I really welcome the questioner's comment, because what it suggests is we're going to have to get past that history and do something different. If our definition of what we need for registrars is based on the way registrars worked 10 years ago, or even now, then I suggest we'll never have enough registrars. If you'd asked someone 10 years ago, will we have enough travel agents or librarians or researchers to match the travel needs or research needs of the people in this room, you would have been way wrong, because I don't know if you've noticed lately, but you don't make travel arrangements or do banking or do research the way you used to. So some of the technical tools and the IT capability, which will both force and, yes, allow us to do things differently from the way we did them, has got to be the only answer to this problem. The answer to this problem, just as it is for physicians, cannot possibly be to train enough physicians to do the work that physicians did 20 years ago. And I guess I would agree with you, we can't possibly solve the person power problem by finding, paying, and training enough registrars to do the registrar work the way the registrars did it 10 years ago either. So in some ways, this is a great opportunity because there are now tools available to do some of the things that we used to have to do by hand, to do them in a new way, and we apparently can't afford to do them in the old way. So I would just argue in some ways, this is a lot like the challenge that's frankly facing primary care doctors and cardiologists and everybody else in medicine, is that in some ways we've kind of held on to doing things the old way because that's the way we were trained to do them and that's the way we got paid to do them. And in some ways, this is a microcosm of what all of our system is facing. So welcome to my world. Yes?
I just had a question about whether or not there are any hospitals or providers that voluntarily make information available about the number of procedures or cases for a certain type of cancer that they treat a year.
Well, so there is something called the Commission on Cancer, which we have not talked about. It's the American College of Surgeons that does work with hospitals and they meet certain requirements and are certified. And among those hospitals, there are registry reports. So if you go on to one of the local community hospitals, that is in fact a part of the Commission on Cancer, you can look up their annual report. You can see how many cases of breast cancer, esophageal cancer. They'll tell you their outcomes in general, but it won't be drilled down to the physician level. It won't tell you the type of procedure that was done or the subsequent outpatient therapy that was given. But it can tell you that this hospital last year treated 400 women with breast cancer or 400 men with prostate cancer. So you could say it has a reasonable volume of patients, whereas if another hospital you don't have any data on or very few, it would give you that kind of crude information.
You know, with the aging population and with more consumers that want to be more informed about their health decisions, how could we go about encouraging hospitals to make more information available? And I don't want to say mandate because that's a dirty word, but how could we do more than encourage them? Because there are more people that want those answers when it comes to
Let me clarify something. Hospitals already are mandated to report, and as we heard, OSHPD does report right now today. Part of the problem, however, is that the definitions of the things that are reported to OSHPD don't necessarily sync up with the definitions that the cancer database uses or the definitions that would be useful to a consumer. So this information is already mandated. It is reported to OSHPD, and it is available, though not easily, through the OSHPD website. The question is, however, how usable it is in this context. So I don't think it's necessarily a question of requiring that they send in some more information. It may be more a question of coordinating that information with other users of the information in different ways.
I could envision a California Healthcare Foundation collaboration with a couple of institutions to do a demonstration project, and then a whole bunch of people saying, wait a second, that's great. I'm going to go there. Well, I'm going to go there unless this other guy has more cases. Well, this guy doesn't even tell me how many cases he has. And we didn't used to know that much about restaurants until Yelp told us that we could click 2 buttons, find out if they're open and if they take reservations and if they take Visa.
Right, and to add on to Roni's comment, I was thinking the ATMs for so many years when you talk about industries. So medicine seems a little bit behind. You know, the banks were open from 9 to 5 if you couldn't get there. Well, then, our work population, they were working from 9 to 5. And now the banks are open on Saturdays, and the ATM, you can get to your accounts, and you don't even have to go to the banks anymore. So to your point, if you had a couple of the economic rewards for being a leader in this area to the institutions that make that information available, seem to be it's the chicken and egg. I think that they will come if you start to build this because people will be interested in having that information available.
Yes, sir.
I have a bit of a mess of a question, so I'll try to make it somewhat coherent. And it's really focused around the issues of quality. That's been something that's been identified in the Iowa report as a priority. also involving the issue of workforce, because we all know that there's probably not going to be enough in this subspecialty to meet demand. And then linking that up with the comments about everybody wants to go to an expert. And I should share with you that my practice setting is that of an academic medical center, and I've been in practice for almost 20 years in the discipline, and I'm responsible for training oncologists, medical oncologists of the future. And so my question to the panelists is your opinion as to perhaps what might be the two most important things that we should focus on in trying to meet all those competing demands, because quite frankly, there's not going to be enough experts. Everybody's not going to go to them. And how do you become an expert if you need experience, if nobody's willing to give you the experience? So, I mean, it's really lovely, but there are some very practical rubber meets the road issues that are going to be very thorny and knotty. And so I'd like some guidance.
I think I can give a really good example, and Bob and I have been involved in a project that's called Athena. Maybe some of you have heard about it, and we have actually looked at, we've looked at it at UCLA, but we've also looked across the system about how women with breast cancer are being followed. And the guidelines, the evidence-based guidelines say that a patient after the first year of treatment probably should be seen maybe 2 or 3 times a year by a physician and somebody to see her or monitor her, and that going out maybe to 3 years, and then maybe every 6 months, and then after 5 years once a year. Doesn't have to be by the oncologist. Well, in our evaluation of the patients, they're seeing, yes, 3 or 4 times a year, but they're seeing 3 or 4 physicians. So there may be 12 to 16 visits to oncology professionals during that time, when maybe 1 or 2 professionals alternating. Now, what's wrong is our reimbursement system doesn't, in fact, limit those visits. We don't coordinate the care. Every time the patient sees another physician who happens to like a test, a PET CT scan or an MRI, that is not evidence-based as a screening test. There are more people touching the patient, more people ordering the tests that may be inappropriate. So if we didn't reimburse that non-evidence-based care, I can tell you the physicians wouldn't be spending their time that way. And in fact, many women with early stage breast cancer could be seen by a nurse practitioner, and certainly could be transitioned to their primary care physician, who they might be seeing already for their blood pressure and their diabetes, and could confer with the oncology specialist with necessary. That's a very, very explicit, but that goes across the whole system, whether it's prostate cancer, whether it's colon cancer. Obviously, when you're in active treatment, you need the oncology people touching you. We need to model team-based care. So I work at an institution where we have very few nurse practitioners. I don't know if are you at Davis? Yes. So we don't, because it's too expensive to have a nurse practitioner, because they can bill at a slightly lower rate. They can't practice at the same scope as a physician because of laws. I work with genetic counselors who I supervise. I have to go in and supervise them for the Medicare and the TRICARE and the Medicaid patients because they can't bill for those. So those are examples of terrible inefficiencies, costs, and wasteful things where, in fact, we could do a better job. So we, as the leaders in academic centers, need to model and emulate that care, but we're driven by how many RVUs are we generating, et cetera. So that's kind of my personal view of where the rubber hits the road in trying to fix it.
Just a parenthetic clarification comment for some in the audience. Cancer benefits from having cancer registries, but cancer is different than other diseases in its complexity. So unlike heart disease or diabetes or a hip fracture, you've got multiple different types of cancer, and you've got oncologists and surgical oncologists and radiation oncologists and nurse practitioner specialists, and anybody that goes to get care for cancer has to rely on the coordination of all those providers to provide efficient care for that particular cancer that they have, whether it's breast or esophageal or multiple myeloma or whatever. So that characteristic of cancer and its treatment makes this more of a challenge, perhaps, than it does for treating hypertension.
I'm not an expert, obviously, in this, except that I'm an expert at being a patient, right? I've also been involved with Athena and the project of course, everybody, if they have their brothers, would like to be with the best person. But I think, when you talk about the gold standard of treatment for, let's say, breast cancer, if the patient was allowed to know, once again, you get back to transparency, if I know that the outcomes of Davis are the same as my rural doctor, because that they're using the Athena network, which attaches whatever Davis and UCSF, that says this is what Dr. Laura Esserman or the UCSF Breast Cancer Center suggests for stage 2B cancer, and you can say to the patient, and we've had relatively the same type of outcomes, I've got no problem about staying with my private practice doctor. Let me give you another example. My dad was recently diagnosed 2 years ago with mantle cell lymphoma. Didn't know anything about mantle cell. Lymphoma is fairly treatable, but mantle cell isn't. There's 4,000 cases a year in the United States. So it really does matter. While the doctor was very excited because he hadn't seen any mantle cell, that was a big, like, very nice to meet you. We'd love to keep you involved on the case. We're going over here to the people that are doing the trials and that are working every day on mantle cell. So once again, I really think it gets back to transparency, because if I know that the place that I'm going in Palo Alto or Sacramento or wherever has similar outcomes to the UCSS and the UC Davises and the Stanfords and the UCLAs, I'm comfortable as a consumer.
Yeah, and you give a great example of portability, and I guess the thing that I'm a little concerned about is that portability is going to become more of a luxury than necessarily true for all. And not everybody's going to have the ability to say, well, thank you, enthusiastic local provider, but I'm going to go to Stanford because they're the world leader on lymphoma research.
Right.
And we can all imagine circumstances in which either reimbursement or logistics or everything else gets in the way of that. And so I was really trying to address that issue of sort of what is quality, what is a good provider, how do we know that they're a good provider, and if they're following guidelines that have been established, if they're following
Right.
evidence-based
So they could have
care.
said, right, so back to the breast cancer example, I think that's a really great step in the right direction, where we're saying these are great research hospitals in the country, and I'm on board with everything that they're doing, and we have similar outcomes. And if and maybe with mantle cell, that's very hard because there's only 4,000 cases, that's the other side of the spectrum. But if they were able to say, I treat 10% of my patients are mantle cell patients, and I actually did a fellowship with blah, blah, blah there, and I'm on board and I know what the care should be,
So I lied. I'm going to say something. There's also, this is echoing what Patty said. We don't play medicine as a team sport nearly as much as we can or should. And this question, in some senses, is framed as an either/or. Are you going to stay with the less famous, less prolific, less quoted local doc, or go to the famous, presumably better one with higher volumes and perhaps some outcomes? And one of the kinds of conversations that we see a lot in the communities is patients saying, I know so and so is awesome and supposed to be the best, so I went there once, and she is now coordinating with my local doc. Right. Now the main thing, there's two things that get in the way from that happening more broadly. One is reimbursement, the other is culture. I don't know a lot about how to fix reimbursement. I think the culture is one that we could work pretty quickly on, assuming that the expert can get reimbursed appropriately for that kind of remote, ongoing consultation or supervision, and that therefore I don't need to know that my local doc has the equivalent outcomes because the expert, without me having to fly there, is just involved enough in the case, and that's potentially scalable.
And there's a lot of people, and once again, when I had said, there's a lot of people that want to choose to be in a private practice. They don't want to be sitting in a waiting room for 4 hours. They don't want, there's a lot, that would be nice for the patients to know up front, because they can make their own decisions. If I'm getting the same drugs and the same care that I would be getting at the big research hospital, but I'm 10 minutes away from and my outcome is as good, there's a lot of people that say, I will take that trade any day.
So we're almost out of time. If I can make one comment on this point. I think it does raise this larger question, the reality that not all of medicine is evidence-based yet. There are some things where the mechanisms are worked out, where the treatment is clear, where in fact people who can't travel don't face a problem because it's clear what to do with XYZ, and any well-trained clinician can do it, and they don't need to go to Stanford. So there's evidence-based medicine, and there's still eminence-based medicine, where it's not well worked out, or there's sufficiently rare that the treatment isn't clear, and there will always be a mix of that. It's not like everything is in one bucket. It does strike me, though, I was at Davis a couple of weeks ago and had a chance to tour the Center for Virtual Care. And the reality is a lot of how doctors learned to be doctors was practicing on poor people. And I'd much rather have the next generation of doctors practice on mannequins and practice on simulations than practice on poor people. Because my sense is you can then train them more quickly and more safely for the patients, if not for them. And so again, once again, our notion of how doctors have to be trained, which is see one, do one, teach one, that's an honored tradition, but probably one whose time has come and gone. So part of the answer to how will we possibly deal with the demand is we're all going to have to do things a little differently from how we've learned to do them in the past. And so I'm optimistic that there are answers. So look, we're at the end of our time. Please join me in thanking our panelists for a great session.